Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is July 14, 2025. This video is on appropriate use criteria 2025 statement for ICDs, cardiac synchronization therapy and pacing, co-chaired by Dr. Andrea Russo and Dr. Milan Desai. It was developed by ACC, AHA, HFSA, HRS and others. Guide evidence-based use of ICD, CRT and pacing. It covers 335 clinical scenarios, including primary and secondary prevention of ICD, indications for CRT, leadless and conduction system pacing, LVADs and post-transplant scenarios. Understanding the appropriateness use criteria rating system, score of 7 to 9, clear benefit over risk, maybe, score 4 to 6, uncertain or variable benefit, rarely appropriate, score 1 to 3, no proven benefit or potential harm. This can be used to support clinical decisions. These are not mandates. Judgment and shared decision making remain essential. ICD, secondary prevention, post-cardiac arrest or sustained VT or VF not due to reversible cause, including CAD with no recent MI or revascularization. Genetic arrhythmias, example Brugada and ARVC. Structural heart disease with sustained VT. ICD is not indicated if etiology clearly reversible, example acute MI within the last 48 hours. ICD primary prevention, LV ejection fraction less than 35%, NYHA 2 to 3 after 3 months of GDMT. It can be included for ischemic or non-ischemic cardiomyopathy. Post-MI patients, ICD typically be delayed for over 40 days. Rarely appropriate if the left ventricular ejection fraction is greater than 40%, there are no symptoms, or non-cardiac terminal illness. CRT, cardiac resynchronization therapy. Who benefits most? NYHA class 2 to 4, left ventricular ejection fraction less than 35%, wide QRS 150 milliseconds, especially left bundle branch block. CRT is appropriate. It may be appropriate when the QRS is between 120 to 149 milliseconds or in non-left bundle branch block. Atrial fibrillation with greater than 98% biventricular pacing. Rarely appropriate if QRS is less than 120 milliseconds. Special populations. Leadless pacing is ideal for prior device infection or limited venous access. Subcutaneous ICD when no pacing is needed, younger patients. In LVAD patients, ICD is reasonable if good functional status and life expectancy is greater than 1 year. In post-heart transplant patients, ICD is rarely appropriate unless arrhythmias are documented. Clinical pearls. Always reassess left ventricular ejection fraction after 3 months of GDMT before ICD. Use guideline-directed therapy as baseline for all decisions. Document rationale for borderline and maybe appropriate cases. Involve EP and heart failure specialists in complex scenarios. Shared decision-making is a must. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.